Welcome to the Innovation Accelerator podcast, brought to you by Innovacer, the health cloud company. We're on a mission to connect and curate the world's healthcare information to make it accessible and useful. With Innovacer, everyone works in the service of patients like never before as one. Visit us online at innovacer.com.
Welcome back to the Innovation Accelerator podcast. I'm your host, Steve Ambrose. On February 24th of this year, the Center for Medicare and Medicaid Innovation, or CMMI, unveiled the new ACO REACH model. REACH stands for Realizing Equity, Access, and Community Health. This model will be a replacement for the December 2020 ACO model, known as the Global and Professional Direct Contracting, or GPDC model. And today, we've brought together a panel of experts to discuss the new ACO REACH model in depth. Dr. Brian Silverstein is the Chief Population Health Officer at Innovacer. Melanie Matthews serves as the Chief Executive Officer for PSW and Northwest Momentum ACO. And Daniel Roberts is the National Director of Value Engineering at Innovacer. Everyone, I want to welcome you to the show. It is a privilege and pleasure to have you all here.
Thank you, Steve, for having us.
Good afternoon.
Thanks so much, Steve.
And before we get into the questions, I'd like to have you each share a little bit about your background. Melanie, let's start with you.
Sure. Thank you. So our organization has been participating in CMS and CMMI alternative payment models since the inception of the direct contracting model. So our organization has really served in 5 years in the next generation ACO. And we also convene MSSP, Track 1 Plus models for another 60,000 lives in Washington. And we've really been committed to being a part of the alternative model space and how to work with CMS and CMMI in advancing the future of paying for American healthcare differently. So it's delightful to be here.
Dr. Silverstein?
Super excited to be here, Steve. I serve as the Chief Population Health Officer for Innovacer. In the past, I've played leadership roles on both the payer and provider side and was fortunate enough to get involved in alternative payment models before the Affordable Care Act even existed, and really excited to see a lot of the progress that we've been making.
And Dan?
This is Dan Roberts, the National Director of Value Engineering for Innovacer. Prior life actually served as the Chief Operating Officer for Chess, an MSO-like organization out of North Carolina. Took a couple of 100,000 lives from a fee-for-service to risk model, and also served in a leadership position with a national Medicare Advantage plan building out their value-based care strategy. And fortunate enough to partner with a lot of intelligent people here at Innovacer, and looking forward to the conversation.
Well, thank you all for your introductions. Let's jump right in. Dr. Silverstein, can you share with us a high-level explanation of the ACO REACH model?
Absolutely. So the ACO REACH model is the current administration's opportunity to redesign a model that was created under the prior administration, as you referenced earlier, the GPDC. CMS actually underwent a strategic refresh, and as part of that, CMMI, which essentially is the testing grounds, also updated their strategy. And part of their strategy is how they're going to drive more accountable care, how they're going to advance health equity, and how they're going to support innovation. What they tried to do with this REACH model was be able to align the model with those strategic objectives. And so how can we get more people into different accountable care models? How can we start to think about health equity differently? And what's interesting in REACH is that they're promoting that you have to have a health equity plan. They're doing some benchmark adjustments. So starting to innovate and test some ideas to be able to better promote health equity and be able to do something that's innovative that ultimately, hopefully, will lead to further iterations and support of the Medicare Shared Savings Program.
And what do you see CMMI, or the Center for Medicare and Medicaid Innovation arm, looking for in its model applicants and future participants?
So CMMI, for their applicants for this particular ACO REACH, are going to do a couple things. First, if you are in the current GPDC model, then as long as you agree to participate with the current requirements and meet the model requirements and have a strong compliance record, you're going to automatically be accepted into the new model. In addition, there's going to be other people applying, and people applying, some of the modifications they're making is really looking at organizations that have physician and provider control. And one thing specifically to meet that requirement is you have to have 75% of the voting members of the governing body have to be physicians and providers. And they're also looking at ways that there's organizations that have experience in taking care of patients that have health inequities and have the familiarity with what this patient population needs and how they can deliver it successfully.
Melanie, what do you see as the biggest benefits to be gained by participating in an ACO REACH model?
So, PSW's legacy business for 27 years has been providing care to the patients in the communities that we serve in a delegated risk arrangement, meaning that we take total accountability for financial and quality performance with health plans. And so what was attractive to us around the CMMI models was that these payment models allow us to take care of whole person care. And I think that the REACH model is the next step in whole person care. So historically and today in the fee-for-service world, healthcare revenue was really generated by volume. And I think that as we look at ACOs, we're really able to see that by generating accountability or having accountability for entire populations, that you can reshape how you use the revenue dollar. And social determinants of health is a case in point. So we've been developing for years programs around those in underserved areas that have had limited access to, healthy food and delivery and medications and social supports and structures. And when you take total accountability in a delegated way, and essentially this ACO REACH model is taking delegation in partnership with CMMI to allow us to make investments into underserved communities. So I feel like this is a great next step in being able to provide the financial model and the waivers and the structure and the benchmark to be able to really encourage ACOs to go into underserved areas. So I applaud CMMI for, really figuring out a way to get into underserved areas. We know that access has certainly been an area that we can say is an underserved access. We decided as a country that healthcare is a right and not a privilege. Yet in those areas that are underserved, it is a privilege to find access. So I think that the intent of this program is to really move that. I'm a recovering medically related social service by background. And so the opportunity to really build the financial model to support the care model is what I see to be very encouraging around the REACH model components.
Dan, ACO REACH appears to be a big step in CMMI's 2030 goal towards value-based care. How do you see value being more greatly realized through ACO REACH? And can you give us a few examples?
Yeah, it's a great question. And I think it's important to think about what this REACH ACO model is truly doing that is different. And it is providing alignment to address things otherwise have gone unnoticed or at least underrepresented, right? And so we think about how much we analyze claims data and clinical data, but we aren't really tracking social determinants of health really at a level that's even comparable. So I think starting the block for that to make sure that we're treating it just as important as any of those other pillars, as we heard Melanie say, as the whole person, understanding what really drives them, it's going to open a whole new segment for us to be able to address preventative opportunities that will align with patients for healthier outcomes before their care gets catastrophic for things that not clinically perhaps were the issue, but truly were social barriers to them getting the care that they need.
And Melanie, I'm going to jump back to you for a second. There's a number of options for participants in ACO REACH when it comes to different types of entities, risk-sharing arrangements, and payment options. Can you take us through these? And we can start with the types of entities.
Sure. You can apply and be awarded the REACH model by being a new entrant, a standard, or a high need. That's the way that you can apply for the program. You can take a professional or a global risk, and there's different arrangements that you take in the risk. So, for example, in a professional track, you're really taking primary care cap equal to sort of 7% of the benchmark. And you also have a 50-50 shared savings arrangement with CMS for those patients and beneficiaries that are aligned to your ACO. Under the global contract, you're really taking 100% risk, and you're taking total care capitation. So I'd say that the professional is the sort of entryway into that model, and then the global would be a full, kind of similar to a full delegated percentage of capitated payment structure. So there are some flexibilities to encourage those that are just getting started in this next level ACO, and being a recipient of both or a member of both MSSP and next generation ACO and now direct contracting. I can tell you that the MSSP track is significantly less administrative structures and alternative ways that you deliver the care. So MSSP, I'd say, is definitely the entry level. But when you move into these other more sophisticated CMMI models, you need to be able to take cap. You have to be able to require discounts from your network. You have to be able to essentially share flow of funds and services in a way that you don't, MSSP is essentially fee for service with a true up at the end on a benchmark. But these models are definitely more sophisticated in nature. I would also say that some of the benefits related to the REACH model, Steve, is that you have flexibilities to manage it in a TIN NPI level, meaning that the provider levels can be in and out, versus MSSP, where you really see one TIN applies for the entire ACO. So you have no ability to sort of tier your network to those that are used to taking risk, because this can be an intimidating and overwhelming process for physicians and providers. And if you meet one physician group, you meet one physician group. I mean, everyone's got a different preparedness or readiness assessment for how prepared and ready they are to take on these next levels of risk. So I do think that it's important that CMS and CMMI continues to provide sort of a menu of services for ACOs to attract new folks that are coming in and meeting them where they are to help, accelerate them over time into more sophisticated, higher risk payment models.
This next question is for the panel. When it comes to picking options for participation, what should provider organizations and current ACOs be considering? And we'll start with you, Dr. Silverstein.
Absolutely. One thing that I really appreciate that CMS is doing and CMMI is, as Melanie indicated earlier, there's a range of different programs that they're offering. So it really is a very interesting way to get more people engaged. When you look at the ACO REACH program, then I would view this almost as this is a very customized play. So it isn't going to be right for all organizations. You're going to want to make sure that you have a lot of experience with direct patient care. And that's an important point of distinction, that they're really looking for organizations that are doing that. They also want organizations that have served historically underserved patients. So they're looking for organizations that have experience with health disparities. And that's really what this model is intending to address, is that if you have this experience, then how can we better support you through some of the financial changes, as well as through some of the waivers, to make you more successful at taking care of those patients. And of course, with all the CMS programs, program integrity is very important. So you have to make sure you're following the appropriate compliance plans.
Dan?
Yeah, absolutely. I think that we've seen a sound investment in the model to where we're going to be adjusting for those regions that otherwise had not been served because it would have required an investment out of pocket by these risk-bearing entities. And so to see an upward swing of, I believe it's $30 per beneficiary per month to a downturn of $6 per beneficiary per month on what that could look like to help bolster the resources that can be placed is going to be huge. As Dr. Silverstein said, this model, though, is not going to be for everyone. I think that they're continuing to refine in a way to focus on the spirit of all of what we're doing here, which is to truly yes, while increasing quality and outcomes, truly lowering the cost of care. And if you are the type of entity that has made your surplus based on risk coding alone, this model probably would not bode as well for a group that's focused more on care coordination, social determinants of health, and addressing those true hard costs.
And Melanie, anything you'd like to add in?
So I would add, as an organization, I would be looking at what is your organizational readiness to participate in those models. So I'm thinking about the maturity index that we do for ourselves and other organizations that we help support, which is how fully evolved are your competencies in the key areas like care management and navigation, business and data analytics, your compensation and engagement model for your provider network. So we have various domains that we look at and say, are we not evolved or fully evolved in those areas? And I would say that as a population health company, that we're continuing to make investments in our own capabilities to become higher evolved on that maturity index in those key areas. And I think that that's where REACH is another evolution, where we're adding that box to really think about what are the social supports in place for that. So I would, as an organization, I would really be looking at whether my capabilities are in place. Like, for example, we're generating remittance, essentially what remittance advices look like. So we're looking at how to simulate the version of what claims could look like so that providers can see what their utilization is and what kind of compensation arrangement that we're entering in with them. Those are capabilities that we have, frankly, because we've been paying claims for over 20 years. So if you're looking to create an investment in REACH, making sure that you're aligning up where you have those services, where you need to potentially seek those services out somewhere else or make investments, et cetera, because it's not the same as just being, like I said, like an MSSP. Another component I would be looking at would be, what is the benchmark consideration for your prospective aligned beneficiaries? So, for example, the REACH benchmark years are 17, 18, and 19. You have some static years in there. But then you think about MSSP and you have 20, 21, 22. In future years, you're using a rolling 3. So we all know that COVID had significant impact on utilization and benchmark. And so it's really an exercise of evaluating the market and how that sort of COVID played out in the communities that you served, and what the behavioral patterns were for seeking medical care or not seeking medical care during COVID. We saw tremendous national variation in utilization over that time of COVID, including what states shut things down and had no elective surgeries, for example, where other states said, we're still going to let you come in and get elective surgery. So that would have an impact on your benchmark years. So I would say, if I was to leave with two main issues as an ACO that I would think about, would be my organizational preparedness to manage closer to the premium dollar from CMS. And then two would be, how does that medical actuary look on your population compared to the national benchmark?
Dr. Silverstein, did you want to add something in on that?
Absolutely. I think Melanie really highlighted some really important considerations. I almost view it as inside baseball, where you really have to understand the details to see if this financially is going to work or not work for you. For example, looking specifically at those years. The other thing that is an important consideration is when you think about a primary care cap, oftentimes, while it seems like doing primary care cap will produce a lot of financial opportunities, usually a lot of the opportunities are for care outside of the primary care office. So you really want to be very thoughtful and deliberate. Even though they're giving you 7% in this program, that may or may not be an appropriate amount for the population. And then in this program, if you do go with essentially the full cap model, the full cap is also essentially for the participating providers. So you have some additional complexity and really wanting to understand who are going to be your providers. So what will that look like financially to determine whether or not this is going to be the right model for you?
I'd like to take the conversation now and move more into health equity. And this is, again, for the panel. Unlike today's ACO direct contracting model, ACO REACH has placed a heavy focus on health equity. So what are the requirements related to health equity for participation in the ACO REACH model? And I'll start off with Dan.
Yeah, it's a great question. It's a huge focus on the model itself. As far as what is required for the groups in terms of social determinants of health, really it's the demographic information being reported. And there's more details certainly to come from that. I think it's much more important to focus on that as a flag being stuck in the ground from CMS, to essentially say that because we're starting this reporting now, it is here to stay and it's going to be taken seriously. There's going to be what could be a 10% bonus in the quality withhold for reporting this out, which is nice, but not too meaningful in the grand scheme of how the model works itself. So really, again, for me, it's much more about this is the start of something. And again, what we're going to be doing is reporting on this information in more detail to make it actual, to treat it just as seriously as claims and clinical data in the future.
Melanie?
I would say that this is a forcing function to require ACOs to do a more robust job at getting data collected directly from the beneficiary. I think it's, kind of interesting if we think about HUD data, Social Security data, tax data. There's a Medicare application data, Medicaid application data. These beneficiaries and Americans are reporting and declaring data. There's not a single source of truth to where all of that data resides, to where we can get really a patient's or beneficiaries' perspective on social determinants of health. And so this is, I think, intended to be this creating the source of underlying data that we need to make decisions, policy decisions, benchmark adjustment decisions, access decisions, et cetera. So I think that the main component of having an health equity plan is that we're reaching into those communities and we're connecting with social service. I said earlier in the program that I was a recovering social service director, and I only did that for a couple of years at the very beginning of my career. But what it did teach me a lot about was that the American healthcare system is based on providing health care, and the social network wasn't really connected. It wasn't really built into electronic health records. It was really, a Rolodex on like Nurse Susie's nursing station with people that she knew that may be able to connect a social connection for a patient that has, social determinants of health that are greatly impacting their healthcare needs, costs, the setting that they receive it in, and so forth. And so I think that this is, again, a forcing function to allow us to have, just like we do for referrals and HIEs and exchanges of data and population health platforms, like we use Innovator as our pop health platform. And so using the social vulnerability index for every patient that we reach out to allows us to not only identify the data that we need for data collection, but it allows us to use that data to prioritize high and rising risk and provide the navigation and helping support. That is really a beautiful thing about ACOs, is it provides and assigns someone that can help patients and beneficiaries navigate the complexity of healthcare. I think that the actual components in the plan are yet to be determined. So we know that there needs to be a plan. There were plenty of questions around social determinants of health in the application process. We reviewed the application process, and I expect that there will be more detail in terms of what that plan needs to look like. So I think having surveys that we fill out, that we handhold beneficiaries through to answer what can be very sensitive questions for folks about, housing and insecurities and food and transportation and mental health, behavioral health and safety. These are sensitive questions. We need to be trained in how to engage with patients and activate them. We need to use that data in a way that allows us to do something meaningful. I have a little pet peeve about asking a bunch of questions about social determinants of health and then not having anything to do about how to help them with those. And so I think that this will allow us to not just provide the data, but to really help the patients in our ACO get connected with those resources.
Dr. Silverstein?
I think that Melanie really highlighted something that's critical, which is health inequities is something that we all know exists. It's very real, but there aren't a lot of very tangible ways to account for that. And something that she said that just really struck me is that what we're doing now is this is the innovation phase. So we know that this is a problem, but we actually don't know, and we know some things to do about it, but we don't know enough to do it in a organized fashion. So what CMMI is really trying to do here is say, we know this is a problem. Let's start collecting some information and then seeing if we can do something about it to ultimately land in other programs. And so specifically, while you have to do a health equity plan, the template for that plan has yet to be developed. So this is something that it's kind of a on the fly, we're going to do this. When you think also about some of the different information regarding social determinants of health, we know those need to be collected, but what and how remains a to be determined. And I think Melanie highlighted some of these things are very sensitive, so you really have to be careful with how you ask them. We've known for decades that social determinants of health have a huge impact on outcomes. I think of something such as the ACEs, adverse childhood experiences, well established from the Kaiser and CDC study. When you have these ACEs, which are 10 essentially, yes, no, these were different things you experienced in your childhood, they have literally a 400% difference in expression of disease as an adult. So it's clear that we need to better understand and collect this. And that's an important thing to remember, that this program is a innovation center program. So there's going to be a little bit of development on the fly. And I'm really looking forward to seeing what people come up with that will hopefully be able to be something that could be contained and moved into all the regular programs.
Dan, Dr. Silverstein touched on this a little bit in his last answer, but are there definitive types of health equity data that ACOs are going to need to collect under ACO REACH?
No, it's a fair question, Stephen. And, I think we're all saying similar things, right? We all believe that likely will be true. But moving for 2023, it'll just be that demographic information that needs to be submitted. And I think more about the other side of it, and that truly is what kind of data can we get that will make us more efficient. And that's what both Melanie and Dr. Silverstein highlighted around the social vulnerability index and really any other tools that help us understand and have an ability to impact. Because just as Melanie said, we don't want to gather this information just to have the statistic, right? We want to be able to move the needle. And we all know that the reason social determinants of health have perhaps been this sort of a laggard on focus is they are so hard to truly meaningfully adjust. And it's going to take a good amount of investment in both time, money, and effort to get us there. But I think that it's certainly possible. And this is a great first step by requiring and getting that snowball going in terms of reporting just the demographic information for the REACH ACO model.
Melanie, I wanted to dive into something here with you. Can you expound a little bit on ACO REACH's health equity benchmark and really how it's going to affect provider payments?
Sure. So the underlying benchmark for the per member per month target pricing, essentially, that one the ACO lives in, will be impacted by this area deprivation index, new acronym alert. But this is the way in which the financial benchmark will accommodate for reaching into underserved sort of zip codes and regions. And so I think that for me, when I think about it from a system and an ACO perspective, I think about how do I look at the data that I have and determine that perhaps starting up a primary care clinic in one of those underserved areas and taking, ACO patients, then they can have better access. I'm reaching into the market and I'm attributing more patients to my ACO. The way that you're attributed to an ACO is because you're seeing a provider. So think about all the patients that are in the community that can't get a provider appointment and they utilize the emergency room as their primary care. And so if we were to be in those communities and they had access, then presumably we could align them to the ACO and we could provide, these wraparound social determinants of health type services that will help impact, the cost and quality for those beneficiaries. So ultimately improving what we want to see in the triple and quadruple aim. So I think that the payment model is designed to encourage those kinds of investments to be made. Where currently, if you went to set up, a clinic in an underserved area, you really can't afford your light bill because the reimbursement is less than your costs. And so I think as we think about our country has a cross subsidy issue that we're trying to correct, and our largest growing payer is Medicaid. And so when we think about Medicaid and Medicare, being such a significant growing type of payer segmentation in our country, we need to be able to manage them more appropriately in the right care setting for the right time. And if people are in underserved areas are using urgent care as their first course of entry to the system, we can certainly help for solving that by providing access in those markets. So the benchmark is designed to encourage that activity.
Dr. Silverstein, I wanted to ask you that aside from providers directly participating in the ACO REACH model, in what ways do you see the push to collect and integrate health equity data and combine it into population health analytics as helpful really for all providers?
Well, as we discussed a little bit earlier, when you think about what's likely to be a predictor for future health needs, that's something that is actually quite difficult to determine. Traditionally, what people look at is historical claims. And when you look at historical claims, you're getting part of the picture. And with some populations, that is a predictor for the future, but in many cases, it's not. I think one thing that all of us know that is a big predictor for the future is behavior, and as well as social circumstances. And there's just no good data sets right now that have behavior and social circumstances. So I think what's really exciting about this is CMS is recognizing this is important. And so how can we start to collect some information that ultimately then people can use? And let's see if we can get a result so that we could then expand this into other models and programs.
Melanie, what are the major differences between the Medicare Shared Savings Programs, or MSSP, and ACO REACH?
So I would say that I touched already on the TIN and NPI impact. I think that that's a big deal around how you attribute patients to the ACO and what kind of flexibilities that you can have. MSSP has like the SNF waiver and a couple other waivers, but the direct contracting and REACH model really doubled down on what next generation ACO had around even Part B cost sharing waivers, waivers to engage beneficiaries. Like if you manage your hemoglobin A1C, then you can have an incentive that can be provided to the beneficiary for engaging in that work. I find that to be a powerful, just scratching the surface on the way to engage beneficiaries in their plan of care. So I think that it's been testing out new methodologies, as well as the in-home visit, which can eliminate the home health required, like OASIS and requirements under home health being homebound and those sorts of criteria that make it challenging to bring caregivers into the home to assess, evaluate, and put a plan and care in place, but they may not need the sort of full meal of services that a traditional Medicare home health benefit would provide. So there's some waivers that are really, I think very helpful in engaging patients in the right care delivery service for the right time, right reason, and so forth. Also, you receive the way that you receive data is another important component. The way that you report your data outcomes is very different. MSSP does a different reporting structure. REACH is claims measures. So there's different ways in which quality data is reported. And then I already mentioned the cost share. But I think the biggest driver for now that I would think about is the ability for us to receive an essentially professional capitation payment and be able to pay upfront for services for providers and offices and care management and coordination fees. So you're essentially, in the REACH model, being able to make the investments real time, where in the MSSP, and I think generally a criticism for those programs, and it's a hard nut to crack, if you will, but it's that you don't see any return for that investment for such a long time period after the performance period, that it sort of loses its juice, if you will, to get providers in the healthcare community excited because it's so far in the rears. It's not as touchable. So you can use the REACH payment methodologies to make those upfront investments. Like we make them for, providing remote patient monitoring and doing investments. All of that is on the ACO dime, so to speak. And you expect that you're going to get that, return by appropriately managing the medical loss ratio and being able to make those investments as you go. That's a very different model than MSSP.
Dan, I really like your title, and I wanted to know a little bit more about value engineering. What is value engineering, and how does it help providers in value-based care arrangements, including the ACO models?
Yeah, no, it's a great question. Value engineering, really, essentially, what we hope to do is make sure that our customers here at Innovacer have the support and partnership that they need, and we meet them where they are. And so really, as we have groups engaging in varying degrees of risk, we can certainly support with risk readiness assessments. But for us, it's much more about understanding what they know they do well. We can then overlay the benchmarks that we've procured from external sources as well as operational information from our customer base in population health to then show another segment of where there could be opportunity for these potential customers. And so what we aim to do is then sequence these value opportunities in ways that have the highest ability to impact quick, and then work your way down. Because we all know that there is an endless list of solutions out there that can be addressed in healthcare itself. What we want to do is make sure that we're focused on how our tool here at Innovacer can support these groups that are taking more and more risk in the provider space. And if it's not something that can be done as a standalone from our product, again, I say we meet our groups where we are. And we're fortunate enough to have partners like PSW that do offer this sort of roll-up solution if it goes beyond that.
Dr. Silverstein, how will CMMI be monitoring ACO REACH participants when it comes to compliance in the model?
So at baseline, I think everyone can appreciate that anytime the government is doing some type of an experiment, which CMMI is, they're very thoughtful, careful, and deliberate with compliance. And that's been the history of the program. And one of the key things is ensuring that Medicare beneficiaries' rights are preserved. And from what I've observed, that absolutely is the case. And all of the participants that I've known and worked with have absolutely been very careful and diligent with that. Specifically, there at times are concerns that different patient rights groups will bring forward, and CMS very much listens to those concerns and modifies their compliance programs and policies to ensure that those concerns are being addressed. And so, for example, anytime a beneficiary has an issue, if they call 1-800-Medicare, those issues end up being investigated. They really do. CMMI also does a lot of analytics, and so they'll do different audits as well as analytics on what types of claims are being done, compare it to different populations. One thing they'll be looking at is Medicare Advantage. And so, for example, are participants in programs going in or out of Medicare Advantage, and what circumstances do those occur? Something that's already been discussed a lot on this call is risk coding. And so that's a continuous debate that occurs. Is the risk coding just more, when risk scores go up, the key question is, are we now more accurately assessing and coding the risk, or perhaps are at times people taking liberties they shouldn't be? And this is a debate that's been a debate for over a decade. And I think what most people have come to appreciate is that when you focus on patients and risk, a vast majority of the risk coding is accurate and appropriate coding. But nonetheless, you have to be very careful and thoughtful with compliance of that. Specifically in the REACH ACO program, there's some guardrails for risk coding that in addition to the demographic adjustments, which are allowed to fluctuate, some limits of 3% for the risk coding related to the beneficiary's risk score. But I think what you can expect is, as CMMI has done with all of their models, is a very thoughtful and thorough compliance program that will, in essence, ensure program integrity.
The rest of the questions we're going to ask here, there's a few left, are going to be for the panel. The first is that the direct contracting ACO model that we have today has what many call a serious problem with transparency, in that beneficiaries can be switched from a traditional Medicare plan to a direct contract ACO without their knowledge or consent. So will there be changes in transparency to alert beneficiaries when their provider organization becomes a participant in the ACO REACH plan? And we'll start first with you, Melanie.
Sure. Well, just like all the ACO models, the requirement is that the ACO communicates to the beneficiary in language that's approved by CMS that they are in fact in an ACO. And I think one of the things, and I have a little bit of confusion myself as to why this is being addressed as a problem, because all of ACOs are still protected by all the Medicare beneficiary protections. So any beneficiary that's in an ACO can go and do whatever within the healthcare system that they would do if they were not in an ACO. So all of the rights and provisions and requirements and protections that are in place via, statute and regulation for CMS continue to be in place. I can speak for myself, having been in alternative payment model space for 6 years, that we've had no movement out of the ACO and into the Medicare Advantage plans or anything that we are delegated for. So we've seen a significant, I would say, stabilization in terms of those that are in ACOs. The other piece is that in a fee-for-service Medicare, there is no beneficiary real support or navigation to manage the complexity of navigating the healthcare community. And I call it adventures and misadventures in healthcare, but we all experience them. And I think the point about the ACO is to have an infrastructure of care navigators and nurses and physicians and so forth that can help them navigate the system. So it's intended to be a value add, not a value take away. And since those provisions are in place, I feel like it's important to ensure that there's, that everyone's behaving as a good actor. But in all of my experience over the last 6 years, I've really never had anything supported or heard that validates that concern. I think the provisions are very clear. I think that we could do a better job, both as the ACO industry as well as CMS, at communicating the value of an ACO for the beneficiary. This is complicated stuff. This is hard to explain to people who know it. And so if you really bring together a beneficiary group, and I rely heavily on Oscar, my beneficiary representative on my board, as I have asked him to repeat back what he thinks he heard me say, because I think that we speak in a language that's complicated in healthcare, and that we need to figure out a way to make that language digestible to the novice and to understand what the value is for the beneficiary, because there are many values for the beneficiary, including cost sharing and helping navigate things like paying for their dog food so that they'll buy their medication. I mean, there's a lot of things that we're managing in that social determinants of health piece that is not managed under fee-for-service models. And so I feel like compliance is extremely important to ensure that we have monitoring and observing and reporting. I'm a big fan of having a very robust, complex, or a compliance program to manage the complexities in which we're managing. But I do not share the concerns about beneficiary protections because they are inherently built into all of the models.
Dan, anything to add?
Yeah, I think Melanie represented that really well. I think, Steve, to your point, it may be about messaging. It may not be a material issue, because in my mind, the REACH ACO model solved for a very big concern that we heard earlier this year, and that was around the geographic model itself. And that was the one that truly lended itself, given the MA ownership implications, where a patient could potentially, and again, I don't think that it would ever happen, but I could see the narrative around a patient being moved from a traditional Medicare into an MA program under that model. But this REACH ACO, it helps separate that and truly does focus on, again, what is the essence of what we're trying to do here. And I think that will help simplify this for us.
And I think the data monitoring of that's going to be important to see if that's shifted. And let's be honest, some of the beneficiary waivers that are put into place, including things that will address social determinants of health credits and things, those are the kinds of supplementary benefits that have inherently been built into Medicare Advantage plans, which has made them appealing for many consumers. Is because they offer benefits that are not, historically built into the Medicare benefit. So I think it's something to monitor, and I think it's got opportunity to do it right. And I think here's our opportunity by adding extra layers of compliance and listening to beneficiary groups and engaging on how we can message the services that are provided.
Our final question for the panel is this. Apart from ACO REACH, what do you see as the biggest driver to move commercial carriers more from fee-for-service to value-based care? And Dan, we'll start with you.
Yeah, so I'm a big proponent of the tipping point, and I think that it has to be a meaningful amount of any panel, any organization, any risk for it to be taken truly serious and have the investment that the early adopters have put in. And I think this is a fantastic step in the right direction.
Melanie?
Sure. I agree with Dan. I think that, we're the tip of the spear here doing value-based care and trying to be a part of the financial model that really facilitates a new care model delivery. So when we're paying for an air conditioner for a patient because when it's smoke in the summer, they get an asthma attack, in a fee-for-service commercial or any population, you wouldn't normally buy an air conditioner, but you're buying it to avoid the emergency room. And you're calling a patient every day who's socially isolated because that social call is keeping them out of the emergency room that they visit every week for stimulation. And so those kinds of services that are built on there, we're proving that out, that managing and coordinating care and doing whole person care provides a better experience for the patient and a more affordable use of our healthcare dollars. As we look at the trust fund and we look at commercial payers, they need to be more and more competitive. It's very important that employers can afford the benefits that they need to fund for employees. And so I think everyone, bipartisan support as well as employer, consumer, government payer, private payer, is that we want to manage costs and quality in a better stewardship, higher quality way. And I think that this is setting the tone for that to be across any market segmentation.
Our thanks to Dr. Brian Silverstein, Chief Population Health Officer at Innovaccer, Melanie Matthews, CEO for PSW and Northwest Momentum ACO, and Daniel Roberts, National Director of Value Engineering at Innovaccer. And for our listeners, don't forget to check the show notes for links to resources and contact information related to today's show. And stay tuned to the Innovaccer podcast for more shows covering the healthcare IT topics that you care about. For more information on this and other healthcare IT topics, please visit innovaccer.com. I'm Steve Ambrose. Have a great rest of your day.
You've been listening to the Innovation Accelerator podcast, brought to you by Innovaccer, the health cloud company. Don't forget to check the show notes for links to related resources and other information. And stay tuned to the Innovation Accelerator podcast for more programs about the healthcare IT topics you care about. Accelerate your transformation and build the future of health on the Innovaccer Health Cloud. For more information, please visit innovaccer.com.